Okay, good evening, everyone. I hope my audio and video are clear. Hello, Anuj. Good evening. I hope
Okay, good evening.
if everything is clear, we can start with the session. Okay. So, yes, thank you, Anuj. Okay, so this is regarding the T20 quiz, which happened for the past 24 hours in the DocTutorials app. And these questions have been handpicked, and somewhat it was there on the difficult range. That's what I heard from those students. Hi, Dr. Idiopathic. Okay. Hi, Agarwal. Hi, good evening. Okay. So we'll start discussing those questions without any wastage of times. No, we'll just stick on to those topic as much as possible. Uh, okay. So we'll start with the first question. A 56-year-old male diagnosed with dyslipidemia was under therapy with atorvastatin, 10 milligram once daily at night. He reported back after 4 months with severe muscle pain, and blood investigations reveal elevated creatine kinase levels. Which of the following genetic predisposition the patient would have been suffering from? Uh, yes, Anuj. Yes, I heard that question also was difficult, right? Don't worry, because we'll be here to explain. We have option A, B, C, and D, and those students who have not attended that test, who are here only for the like knowledge purposes, you try to stop this video, pause this video in between, try to come up with the answer, and after that you can proceed on with the sessions, buddy. Good. So the answer for this question is actually option A, decreased uptake of statins into the liver. Well, that is the answer for the question, option A. But we'll explain how and why in few minutes. See, we have certain transporters which is present over the surface of the liver. These transporters might be of two major subtypes. One are named as uptake transporters, the other one is efflux transporters. Uptake and efflux transporters. Of course, as the name itself implies, uptake means anything which is roaming in the blood will be moving into the hepatocytes. Efflux means those molecules which are there inside the hepatocytes will be thrown into the blood, which means efflux going out of the heart, out of the hepatocytes. Uptake transporters, we have multiple different subtypes. All of these things are together called as OAT transporters, OAT family. Out of this, we have OAT P1, B1. Similarly, we have OAT P2, B1, P1, B3. Lots of different subtypes are there. I've given you a basic subtype of it. Efflux transporters, we have MRP type 2. This is the family of those areas, guys. Within this MRP, we have lots of subtypes like MDR type 1, then your breast cancer resistance proteins, BRCP. All these molecules will come under MRP. Now here, the function of OATP1B1, and that's what is an important, that's the one-liner of this question. Consider here is where your hepatocytes, on the surface of hepatocytes, we have this OATP1B1 gene or OATP1B1 protein. This is an uptake transporter, which means whenever statins are there, these statins is going to be taken up into the hepatocytes via this transporter. That's what is called as an uptake transporter. Now, this is nothing but your hepatocytes, as we have discussed. This is your hepatocytes. What is the mechanism of action of statins? It tend to inhibit HMG-CoA reductase enzymes, which is present inside the hepatocytes. So this OATP1B1 gene or the protein or the transporter is primarily responsible for uptake of statins into the hepatocytes to see the pharmacological responses of statins. But unfortunately, there are certain areas, for example, there might be some genetic predispositions where the OATP1B1 transporter will not be functioning properly. Or one more mechanism, a famous drug named as cyclosporin. These cyclosporins and genetic predispositions will be inhibiting this OATP1B1 transporter. Whenever this transporter is getting inhibited, what will happen to statins? Statins will be accumulated there inside the blood. Well, that's the reason those statins which are getting accumulated there inside the blood, where it will gain entry, because it cannot gain entry into the liver cells. Instead, it will gain entry into the muscles. Thereby, it will start producing myalgia and rhabdomyolysis. myalgia, and rhabdomyolysis. So here, the concept is this patient is actually a 56-year-old male diagnosed with dyslipidemia under a statin therapy. After 4 months, he presented with severe muscle pain, and blood investigations reveal elevated creatine kinase levels. Which of the following genetic predisposition? The issue here is there is decreased uptake of statins into the liver. That's the reason why statins are accumulating there inside the blood, causing muscle toxicity. Increased uptake of statin into the liver, no, it will not predispose the patient for myalgia or rhabdomyolysis. Decreased systemic activity of statins, no, because more systemic activity of statins is what the reason for myalgia or rhabdomyolysis. Increased rate of metabolism of statins, no, if statins are quickly getting metabolized, the patients will not land up in rhabdomyolysis. So the answer for this question is option A, guys. Good. We'll move to the next question. Match the drug with its adverse effect. First of all, we have 4 different drugs, which is not even coming under any particular classification. First drug, inamrinone. Inamrinone is a specific phosphodiesterase 3 inhibitor. Phosphodiesterase 3 inhibitor used for heart failure. We have a derived drug called as milrinone. Milrinone is the drug which is commonly being used. Inamrinone is not being used commonly. Why? Because inamrinone is associated with thrombocytopenia, fatal thrombocytopenia. And of course, these phosphodiesterase 3 inhibitors also might induce the patient to develop arrhythmia. That's the reason why inamrinone drug is not been, or even milrinone is not been preferred for chronic heart failure. Is used only for acute heart failure. Dapsone, on the other hand, is an anti-leprotic drug. This dapsone is associated with hemolytic anemia. Dapsone is associated with hemolytic anemia whenever it is given in patients with GCSPD deficient individuals. I'm getting an answer option C and option A. Lots of different question options have been there in the chat options. No problem, I'll explain that. Isoniazid is an anti-tubercular drug. Most of you would have cracked it, no? Isoniazid will be producing peripheral neuropathy. Most of you would have been knowing it. That's why all of these options I have given 3D, right? It's already been there in the options. Sulfonamides, on the other hand, will be producing hypersensitivity reactions because sulfa drug allergic reactions. So 1B, okay, 1B, 2C, which means yes, 2C, 3D, and 4A. This is the answer for this question. Yes, you're right, doctor. Option C is the answer for this. Good, Indu, Anuj, good. We'll move to the next question, guys. A 35-year-old male was diagnosed with COPD. Which of the following drugs has the potential to cause bronchoconstriction and thus avoided in this patient? Aclidinium, ipratropium, tiotropium, and revefenacin. This is a famous question, like taken up from a single one-liner, and that one-liner is ipratropium bromide will be producing, good Dr. Anuj, the answer is option B. Ipratropium bromide will be inducing bronchoconstriction. And why is it producing, my dears? I'll give you a simple example for that. Consider here is where your presynaptic terminal, and we have the bronchial smooth muscles. This is your bronchial smooth muscles. And inside the presynaptic terminal, we have acetylcholine stored over there. Now, on the presynaptic terminal, we have M2 receptor, which is a GI coupled receptor. And over the bronchial smooth muscles, we have M3 receptor, which is a GQ receptor. This is GQ, this is GI. The function of M2 is to produce inhibition of the release of acetylcholine, whereas M3 receptor on stimulation will be inducing bronchoconstriction because it is GQ coupled. It will release calcium along with it. Now what happens is whenever you administer ipratropium bromide, this ipratropium bromide will be not selective for M3. We need blockade of M3, but it will not be selective for M3. Instead, it will be binding up with M2 and tend to inhibit it. First of all, ipratropium bromide is an anticholinergic or antimuscarinic drug. When M2 receptor, the normal function of M2 is to block the release of acetylcholine, but when you inhibit that receptor, inhibitor of the inhibitor, simple, negative into negative is positive. It will start engulf, it will start producing more release of acetylcholine into the synapse. Continuous release of acetylcholine in turn will stimulate all the M3 receptors on the bronchial smooth muscles. Thereby, this might produce bronchoconstriction. This is what we explain as paradoxical bronchoconstriction seen with ipratropium bromide. And that is the reason why we don't commonly use this ipratropium bromide for the treatment of COPD. So what about the other drugs, sir? Aclidinium, tiotropium, revefenacin, all these drugs are also antimuscarinic agents, but these drugs are more M3 selective agents. These drugs are more M3 selective, whereas ipratropium bromide is not an M3 selective agent. It will bind with both M2 and M3. That's why the answer for the question is option B. Yes, Dr. Indu Sumit, the answer is option B, my dears. Revefenacin is also an anticholinergic agent. We used to call revefenacin as a LAMA drug, long-acting muscarinic antagonist agent. It has got a longer duration of action, like also tiotropium, that is also having a longer duration of action. And these drugs are also more M3 selective agents. Good. We'll move to the next question. Desmethyldiazepam is the long-acting active metabolite of all of the following benzodiazepines except. See, this drug appears like pharmacokinetic or difficult based questions, but no, guys, this question is actually taken from an important, like one-liner, important PYQ also. And that PYQ is which of the following is a longer acting drug, which of the following is a short acting drug. Well, that's what the PYQ states for. See, we have diazepam, chlordiazepoxide, prazepam, alprazolam. For understanding that, I'll be giving you an image which is taken up from Katzung. This is the image which is taken up from Katzung. As we can see over here, we have chlordiazepoxide, diazepam, prazepam, and chlorazepate. These are the inactive forms. And all of these will be having a common active metabolite, which is desmethyldiazepam. This desmethyldiazepam, which has been formed, has got a longer half-life of around 40 hours. It has got a longer elimination half-life of 40 hours. That's the reason why all of these drugs tend to have a longer duration of action. But on the other hand, as we can see, alprazolam and triazolam will be metabolized to alpha hydroxy metabolites, which in turn will directly land up in conjugation, which is glucuronide conjugation. Phase 2 metabolism will happen, thereby it is going to be excreted out. Whereas on the other hand, lorazepam, there is no even alpha hydroxy metabolite. Directly it will be conjugated with the glucuronide, thereby it will be converted to an inactive segment. That's the reason why lorazepam has got a shorter duration of action, because it will be quickly metabolized. There is no longer acting active metabolite for lorazepam. A longer acting active metabolite is seen only for those chlordiazepoxide. Out of this, the commonly used one is chlordiazepoxide and diazepam. That's the reason why these two drugs tend to have a longer half-life, whereas lorazepam tend to have a shorter half-life. This is taken up from a PYQ, I think INACT 2022, I suppose. That is they have asked about which of the following has got a shorter duration and which of the following has got a longer duration. So as per the image, the answer for the question is option D, alprazolam, because all the other drugs tend to have a longer acting desmethyldiazepam. Good. We'll move on further. Okay, so whenever you come across this image like a blue man syndrome or a Smurf skin appearance, usually you will be thinking about one famous drug, but unfortunately that famous drug is not there in the options. Right? I hope that I got lots of black flashes and lots of students said, "Sir, what did you do with that question?" Okay, so I'll explain that. Don't worry. See, here the answer for this question is actually retigabine. This is blue discoloration of skin body. The answer for this question is retigabine. What exactly is retigabine? Okay, Anuj Kumar is asking whether they are safe in liver failure. No, lorazepam is safer in liver failure. A longer acting drug usually is not being done. It's not being given in terms of liver failure because these longer acting metabolites might get accumulated, right? So whenever it's getting accumulated, we can see a prolonged response, a prolonged sedative or hypnotic response. That's why these drugs are avoided in terms of liver failure, diazepam and chlordiazepoxide. Instead, we can opt for lorazepam in those cases. Yes, Dr. Amidaron was the question which or the options which we're thinking about. But here we'll be talking about retigabine. Retigabine is a potassium channel opener drug. It's a potassium channel opener. As you can see, all of these four are anti-epileptic drugs. So one anti-epileptic drug is going to be inducing blue man syndrome or blue discoloration of skin. How it is going to be produced? Retigabine will be having a metabolite named as N-acetyl retigabine. This N-acetyl retigabine has got high affinity with melanin. It has got high affinity with the melanin. Whenever it is binding up with the melanin, it might induce blue discoloration of skin. Blue discoloration of skin. So retigabine also not only amiodarone on body, even retigabine is associated with the blue discoloration of skin, or a blue man syndrome also can be seen with retigabine, which is again an anti-epileptic drug. Of course, what about the other options? Tiagabine, on the other hand, the name appears very much similar, but the adverse effects are entirely different. Most commonly, patients might develop confusion and ataxia, the two common adverse effects of tiagabine, whereas topiramate, on the other hand, will be producing dysnomia. What is dysnomia? Naming difficulty or remembrance issues. All of these are cognitive impairments, are very much common, like the most common cause of non-compliance. If a patient is under topiramate therapy and the patient themselves will stop taking it, why? Because of this cognitive impairments. The second most common adverse effect is going to be paresthesia. Paresthesia is the second most common. Also, patients might develop lithiasis. Urolithiasis might also be seen, but it is not a common adverse effect, guys. Just 5 to 15% is the incidence. Dysnomia and paresthesia are the most common ones. Other side effects of retinol, Dr. Monica, don't worry. Primarily, it is not being used currently in practice because of this particular reason, blue discoloration of skin. It is usually not being preferred. Good. And it has been previously approved for focal seizures, but currently we don't usually opt for that. But of course, we know that we have seen lots of banned drugs asked in the exams also. So this is also an important question for you. Good. With this, we finish off this question, guys. Sorry. I'm just recovering from a severe LRA individuals. Yes, Dr. Monica, you're right. Visual defects, okay, visual defects, dysnomia, weight loss. Weight loss is one of the important adverse effects of topiramate. What about this question? A new antiretroviral drug is under study. After getting approval of IND, phase 1 clinical trial is getting designed. Who will be the study participants involved in this phase 1 trial? Yes, this is a question which a small twist in it, because usually we know phase 1 clinical trials will be involving healthy volunteers. But here, please note on that usually phase 1 trials will be involving healthy volunteers. But if that phase 1 trial is being done for an anti-HIV drug which is targeting, or antiretroviral drug, or an anti-cancer drug, if you are studying an antiretroviral drug or an anti-cancer drug, then phase 1 trial will involve target population. Well, this is what the small twist in the question, guys, right? So phase 1 trial, which if the study drug is going to be antiretroviral or anti-cancer drug, phase 1 trial itself will not be like exposing a normal human being, healthy volunteer, to those anti-cancer drugs or antiretroviral drugs. So usually the answer for this question is going to be option D, patients with HIV. That will be the answer here. That's a small twist for all, not for all phase 1 healthy volunteers. If the phase 1 study, the study drug is going to be HIV, anti-HIV, anti-cancer, then the target population would be like patients with HIV. Moving on to the next question, guys. A 47-year-old known case of chronic renal failure was admitted with DVT, deep vein thrombosis. Which of the following drug is contraindicated in this patient? Yes, doctor. Yes, Dr. Anuj, for anti-cancer drugs also. Anti-cancer drug and also antiretroviral drugs, we can phase 1 clinical trial will involve a target population. Okay, so answer for this question, we have unfractionated heparin, enoxaparin, which is a low molecular weight heparin, and we have fondaparinux, both B and C. Is it option A, option B, C, or D? Please pause it, try it out, and now we can go for the question, go for the proper answer here. See, the answer is option D. Option D, both B and C will be the answer over here. Please note down, both enoxaparin and also fondaparinux are contraindicated if the creatinine clearance is less than or equal to 30 ml per minute. This is one way of the contraindication, but good. All of you have come up with the right answer. Good, Dr. Anuj, educate me. Good. CHSO 0831, good number. Thank you. But that's also the right answer there. If creatinine clearance is less than 30 ml per minute, these drugs are contraindicated. And also, if the serum creatinine levels is more than 1.8 milligrams per deciliter, again, these drugs are contraindicated. But how do we monitor the response? We have to monitor the response by taking up the factor 10A assay. because we know that APTT prolongation or APTT changes will not be very much evident when the patient is under low molecular weight or fondaparinux. So how do we monitor the response? Factor 10A assay has to be done. So that's why these drugs are contraindicated. In terms of renal failure, which drug can be given, which is drug of choice in those cases, then the answer is going to be unfractionated heparin. But here they have asked which of the following drug is contraindicated. That's why the answer is option D. Good, Dr. Bharat, Monica, Indu, good, you're all right. Sorry. So here, Monica is saying option B might be the answer. No, enoxaparin, not only enoxaparin, even fondaparinux also is contraindicated in renal failure. Moving on to the next question, buddy. How much of a drug with pKa 8 would be there in unionized form when exposed to an environment of pH 5? Good. So here, this is primarily based on a famous formula. I hope you remember that. If D is equal to 1, one form would be 10%. A famous thing which we have repeatedly sold in all our classes. So if D is equal to 1, one form would be 10%. If D is equal to 2, we have to put 1 point before, no? So 1%. If D is equal to 3, put 1 point before, 0.1%. If D is equal to 4, again put 1 point before, 0.01%. But I will say what exactly is D, don't worry. So D is nothing but the difference in the pH, difference in the pH between the drug and the environment. Here, what is the difference? 8 minus 5 is 3, which means D is equal to 3. One form would be 0.1%, the other form would be the remaining 99.9%. Good. Now we have come up with the value. One form is going to be 0.1, the other form is going to be 99.9. But here you have to look into that. If the pK of the drug is around 8, it means that it is an alkaline drug or a basic drug. The pH of the environment is 5, which means it's an acidic environment. And a basic drug is put up into an acidic environment, different medium. So majority is going to be there in the ionized form. And that's why 99.9% would be there in the ionized form. 0.1% would be there in the unionized form. And that's why the answer for this question is going to be 0.1%, because they have asked how much percentage is going to be there in the unionized form. Sorry. So please remember this difference, guys. D is equal to 1, one form is 10%. So the remaining is going to be 90%. Well, that's how the system works. The answer for this question is option A. Good, we'll move to the next one. A 19-year-old female presented to the OPD with complaints of tingling and numbness in her legs and upper arms. She reveals that she took small doses of pesticide with suicidal intention. She was given lavage by her relatives, following which she recovered. Which of the following drugs would have prevented this? Don't Yes, doctor, educate me. Yes, we have to go a little bit more deep in it. Anuj, no problem, because it usually happens. This is not a final test. I'm just giving you all the raw areas to be getting exposed. So which of the following drugs could have prevented this? First of all, please note that this is not a case of acute organophosphorus poisoning. Right, so this pesticide, usually whenever you go for pesticide, you think about organophosphorus compounds poisoning. For when you think about acute OPC poisoning, you immediately opt for atropine, but here atropine is not the answer. That's the reason why we have put up this question, because this patient is not suffering from acute overdose. Patient has consumed a small amount of organophosphorus, and the patient lavage was done in their own home itself, and after that the patient was revoked back normal. Right, now the patient is presenting with tingling and numbness. The thing which she is currently developing is organophosphorus compounds induced delayed neuropathy, called as OPIDN, organophosphate induced delayed neuropathy. This organophosphate induced delayed neuropathy will be developing after 1 to 3 weeks of getting exposed to a pesticide. It will start to develop after 1 to 3. Patient would be normal, but after that, slowly they will start developing tingling and numbness. And usually, the tingling and numbness or the peripheral neuropathy will be of stocking and glove pattern. You know, stocking and glove neuropathy, right? She, of course, glove, both in the anterior and the posterior area, and stocking still the hip. In all these areas, there will be pricking sensations. And the only drug which would have prevented this OPIDN from, there is no proper treatment for OPIDN, guys. If a patient develops, there's the usual multivitamin or vitamin B12 injections would be useful, but there is no like documented treatment for it. Primary modality is going to be prevention. Here we have to prevent this OPIDN, and that's the reason why we give 2-PAM or nothing but pralidoxim has to be given in those cases. Good, majority of you have guessed it right, because atropine is not the answer. Atropine will be the answer for acute OPC poisoning. This is not an acute OPC poisoning. Succinylcholine cannot be used. It has got no role with delayed neuropathy. Even if a patient is developing acute OPC poisoning and lands up in any issues like respiratory failure, even in those cases, for induction of artificial respiration, we should not use succinylcholine, because already the issue is too much acetylcholine here, because esterase enzyme is getting inhibited by organophosphorus. Succinylcholine is contraindicated in those cases. We can opt for rocuronium. Rocuronium is the skeletal muscle relaxant of choice for induction of artificial respiration in patients who are suffering from organophosphate-induced respiratory failure. Pyridoxine with physostigmine, this is like a bullshit combination, so don't worry about it. The answer for this question is option B. Pralidoxime is the answer for this question. Good. Okay, we'll move to the next question, guys. This question is somewhat easier for you. Which of the following statements is false regarding diuretic agents? Option A, astazolamide has astazolamide has a self-limiting diuretic effect. This statement is a true statement, guys, because astazolamide is a bicarbonate uric drug. At one point of time, the body, because bicarbonate is getting let out, at one point of time, patients will land up in acidosis. Severe acidosis will prevent the further excretion of bicarbonates into the urine. That's why we say astazolamide has got a self-limiting diuretic effect. After some time, the effect will be stopped. Good. Second statement, thiazides might cause 5 to 15% increase in the total cholesterol level. This is also a true statement. There will be an increase in the total cholesterol and also the triglyceride levels that is seen with thiazide diuretics. Among loop diuretics, furosemide causes least orthostatic hypotension. This is the false statement, buddy. This is the black sheep here. Good or runners, the answer is option C. Why? Because furosemide tend to produce most orthostatic hypotension. Out of all the loop diuretics, the drug which causes maximal orthostatic hypotension is furosemide. That's the reason why this statement is false. Whereas osmotic diuretics can be used for barbiturates and salicylate poisoning. Yes, this is a true statement. So the answer for this question is option C. This is the, I think that's false they have asked. This is a negative faced question. So the answer for this question is option C. Let's move to the next question. A 34-year-old female is under long-term therapy with omeprazole. I don't know why she is under long-term therapy with omeprazole. Which of the following can be expected in this patient? Microscopic colitis, colonization of multi-drug resistant bacteria, atrophic gastritis, and hypergastrinemia. Good. See, the answer for this question is all of these four, right? These are the adverse effects of proton pump inhibitors, PPIs. How do we remember these adverse effects of proton pump inhibitors? And we're giving you a mnemonic over here. MICA is the mnemonic. MICA is the mnemonic for remembering the adverse effects of proton pump inhibitors. M stands for, okay. Okay. M stands for microscopic colitis and calcium, magnesium, vitamin B12, and iron malabsorption. I stands for intestinal infections, especially Clostridium difficile associated diarrhea can be developed. C stands for colonization of multi-drug resistant bacteria. A stands for atrophic gastritis. H stands for hypergastrinemia. All of these are adverse effects of proton pump inhibitors. A very, very important thing for the exams, because we have recently found a drug called as revaprazan and vonoprazan, which are potassium competitive acid blockers, PCAD drugs. And these drugs are mostly designed to replace the proton pump inhibitor which is there in the market. So you will be landing up in the question primarily targeting proton pump inhibitors adverse effects. So please remember all these points, very, very important one. So the answer for this question is option D, 1, 2, 3, 4. All of these four is the answer for the question. Good. We'll proceed on, guys. We'll proceed to the next question. All of the following functions in the gastrointestinal tract will be decreased by administration of opioids. except, please note it down, your motility, GI motility will be decreased. That's why patients will land up in, I'm getting option A, option D. Okay, we'll look into the options, don't worry. Motility will be decreased, guys. So it will not be, because the question is all of this will be decreased except, which means it is going to be increased in those cases. Motility will be decreased, so patients will land up in constipation. Progressive peristaltic waves, again, peristalsis is going to get decreased. Again, motility will be decreased, so there will be constipation. Gastric secretion will be decreased. Resting tone is going to be increased. That's the reason why patients might land up in periodic spasms. There will be periodic spasm development. That's why resting tone of the GI tract, primarily the middle part of the small intestine, the resting tone will be increased up. That's the reason why patients will be having abdominal pain. Crampy abdominal pain might be developed whenever patient is under opioid therapy. Of course, most of you would be knowing that opioid-induced constipation, there is no development of tolerance. And not only for that, even for meiosis, there will be no development of tolerance. That is a question which is a derived question from this. But the primary question here is resting tone is the answer for this question, because that is going to be increased. All the others which will be decreased. Good, we'll move on. Which of the following drugs approved for Bardet-Biedl syndrome causes this adverse effect depicted in the picture? First of all, what is this Bardet-Biedl syndrome? This is an autosomal recessive disorder, primarily a primary cilia defect. This is a primary cilia defect. Patients might land up in obesity. Patients might develop obesity, microorchidism, polydactyly, and multiple different symptoms, guys. There are many different mutations which are found to be related with this Bardet-Biedl syndrome. But here, don't worry about it, because the primarily here we are talking about a drug, and that drug name is setmelanotide. Setmelanotide is the only drug which has been approved for Bardet-Biedl syndrome, which is a melanocortin receptor agonist agent. It is a melanocortin receptor agonist agent. That's why the answer for this question is actually setmelanotide. Okay, Bardet-Biedl syndrome we have understood, but what about this adverse effect? This is nail pigmentation, guys. This is nail pigmentation, which again I have given you the list of adverse effects of setmelanotide. Here we have depression, sexual adverse effects, hypersensitivity reactions, and skin and nail hyperpigmentation can be seen with setmelanotide. These four are the major adverse effects of this drug, and that drug is the only drug which is approved against Bardet-Biedl syndrome. And here they have given the nail pigmentation. That's why the answer for this question is setmelanotide. What about liraglutide? Liraglutide is actually a GLP-1 analog agent. Semaglutide, again a GLP-1 analog agent. All of these drugs are approved against obesity. But the drug which has been approved for obesity associated with Bardet-Biedl syndrome, and the drug which is associated with the hyperpigmentation in the nails, the answer is setmelanotide. Good. We'll proceed on further. Which of the following statements about stiripentol is false? What exactly is stiripentol? Stiripentol is an anti-epileptic drug. Okay. We'll look into the first statement. It is used in conjunction with clobazam and valproate for Dravet syndrome. That is the only approved indication for stiripentol till now. And that's why this statement is a true statement. It increases the central levels of GABA. This is also a true statement. It has got multiple actions with the GABA, guys, because either it might increase the levels of GABA, or it can block the reuptake of GABA, or it can also inhibit the metabolism of GABA. Primarily, the action is it will increase the levels of GABA inside the brain. Thereby, it will induce inhibition. It is a potent inhibitor of cytochrome P3A4, 1A2, and 2C19. Again, it is a true statement. Stiripentol, I hope you remember that like Queen Priyanka Chopra mixes vodka with ice. That demonic which we gave for microsomal enzyme inhibitor, there we have spoken about stiripentol there. And the last statement is it might cause weight gain, so contraindicated in obesity. This is a false statement because it will not produce weight gain. Instead, it will produce weight loss. That's why it can be given in terms of obese individuals who are also been diagnosed with epilepsy. Good. So this is the false statement, and that's why that is the answer for this question, because they have asked which of the following statements is false. It's a negative faced question. Good, Anuj, Indu, good. I think most of the questions you are answering. I'm very much happy that you are in a good stream and good path. We'll move to the next one. Siraparantag, a reversal agent, is used for all of the following drugs overdose except. Okay. So please try to pause this question, and because why I have put up the question is, again, this is a contradictory statement pertaining to a previous year question. Previous year question stated Siraparantag has been used against dabigatran and edoxaban. It is an universal antidote for all directly acting oral anticoagulant agents. But they have given in lots of different Q banks, they have explained that it has not been effective for low molecular weight heparin. Well, that is the one, because option C, good doctor Anuj, Saritra, Jigate, Monica, Rutuja, good doctor, because the option C is easier, you can easily guess it because warfarin is there. Please note down that Siraparantac, we have a recent update here. Siraparantac can be used for low molecular weight heparin, especially low molecular weight heparin. Can be used against dabigatran, can be used against edoxaban. That's why option C, warfarin, is the answer for this question. Because warfarin, the specific antidote is vitamin K. And if a patient lands up in warfarin-induced bleeding, then prothrombin complex concentrate will be the treatment here. Good. So the answer for this question is option C. Siraparantag can be used against low molecular weight heparin overdose also. The next question, match the following drug with its mechanism of action. This was a little bit difficult for some of the students. They have told, we'll explain that. Adalimumab, it is an anti-TNF alpha monoclonal antibody. TNF alpha, okay, I'm getting answers. Option C, we'll look into that, but I don't worry. So TNF alpha, I hope you remember that, Adingosir. Yep. Adingosir drugs, right? Adingosir drugs are all your TNF alpha monoclonal antibodies, which is adalimumab, infliximab, golimumab, and certolizumab. Certolizumab. All of these drugs are anti-TNF alpha monoclonal antibody. Inclisiran is a PCSK9 inhibitor, proprotein convertase subtilisin kexin type 9 inhibitor. We have two monoclonal antibodies like your evolocumab and alirocumab used against dyslipidemia. Evolocumab, alirocumab. Also, we have an mRNA derivative agent which is inclisiran, and that's why option 2 goes for option A. Sotatercept. What is this sotatercept and resmetirom? Most of you would have guessed. Good daughter Anuj, Saritra, Lucifer. Good. Lucifer part 1 or part 2? Okay. Lucifer monster. Good. Okay. So resmetirom, most of you would be knowing it because it has been covered up multiple times in lots of medicine question also. It is targeting THR beta, primarily approved against NASH, non-alcoholic steatohepatitis. Sotatercept, will be explaining about that. See, consider here is where your pulmonary blood vessels are. Here is where your pulmonary blood vessels. Pulmonary blood vessels is going to be acted upon by two different concepts. One is BMP protein, the other one is activin protein. BMP and activin. This BMP, whenever it is binding up with the BMP receptor, that will induce inhibition or it will prevent the proliferation of pulmonary blood vessels. Whereas on the other hand, activin, if it is binding up with this receptor, that will stimulate or it will induce pulmonary blood vessel proliferation. So, in terms of pulmonary hypertension, what exactly is happening, buddy? This sequence which we have drawn, this activin sequence is acting up more, whereas BMP sequence is acting up less. Well, that's the reason for pulmonary, one of the mechanisms of development of pulmonary hypertension. So what we have done, we have designed a fusion inhibitor. I hope you remember that. So sotatercept. If a drug name contains sept, it is an interceptor. It is a fusion protein. So we have designed a drug which will be binding up with the activin, and that is sotatercept. When I inhibit that, as simple as that, that will prevent the proliferation of pulmonary blood vessels. Thereby, it can be used for pulmonary hypertension. So sotatercept is a drug which tend to be binding up with activin molecules. It is targeting activin. Good. So here what will be the answer, guys? 1D, okay, 1D, 2A, 2A, 3B. Okay, option D is the answer for this question. Option D is the answer for this question. Happy to see that lots of you have guessed it right. Good. We'll proceed on further. 54-year-old known case of HIV was brought to the emergency with a recurrent attack of seizures and neck rigidity and was diagnosed as often they have given the diagnosis cryptococcal meningitis. Which of the following drugs can be used in these patients if liposomal amphotericin B is unavailable? Well, that's what the twist in the question is. Most of you would be knowing that cryptococcal meningitis, we can manage it with liposomal amphotericin B, but which can be given in case LAMB cannot be administered, or we can put it up in a different way. If IV route is not been possible, if intravenous administration is not been possible, then which drug can be given? I'll give you the sequence of therapy in terms of cryptococcal meningitis. Good Dr. Saritra Rukmar, educate. Good Dr. Anuj. See, in terms of induction therapy for cryptococcal meningitis, we have to go for LAMB, liposomal amphotericin B, in combination with flucytosine. Well, that is the treatment of choice. Induction therapy given for 2 weeks of time. Good. Now, if because LAMP we know we had to be administered via intravenous routes, if IV is not possible, if intravenous route is not possible, then we can opt for the second drug dose regimen, which is a high dose fluconazole in combination with flucytosine. Usually we go for a dose of around 800 to 1200 milligrams, guys. Somewhat a moderate dose to a high dose. But if a patient is suffering from HIV, we have to opt for a high dose regimen. If a patient is not suffering from HIV, we can go for a moderate dose or a low dose regimen. Here, as we can see, this patient is a known case of HIV. That's why we opt for a high dose regimen of fluconazole. 1200 milligram is the dose which we commonly use. And of course, what about this flucytosine? We have some ifs and buts for LAMB. That's why we have changed it with fluconazole. What about flucytosine? Flucytosine dose must be reduced or in terms of renal failure. There should be dose reductions in renal failure. And number two, if flucytosine is contraindicated, then we can opt for liposomal amphotericin B with fluconazole as the combination. See here, we have lots of ifs and buts, no, because all these points are very much important, especially for cryptococcal meningitis. So for cryptococcal meningitis, the treatment of choice, the question asked, LAMB with flucytosine. But if LAMB cannot be given, high-dose fluconazole can be replaced. If flucytosine cannot be given, LAMB with fluconazole. Fluconazole is always took it up as a replacement mechanism. That's why, as most of you have guessed, the answer for this question is high-dose fluconazole with the flucytosine will be the answer. We should not administer conventional amphotericin B because patients might land up in renal failure and allergic reactions too. The next question, buddy, a 36-year-old woman, a known case of bronchial asthma, was put on aspirin and atorvastatin combination therapy as a secondary prophylaxis of her ASCVD, atherosclerotic cardiovascular disease. After 7 days of therapy, she presented with severe exacerbation of bronchial asthma. Which of the following best explains this mechanism? Okay, just attempt this question, pause this, and because there are lots of options. Option A, we have aspirin induces lipoxygenase activity. Most of you went for option A when I looked into the statistics actually. Atorvastatin causes bronchoconstriction when given with aspirin at low doses. Aspirin increases PGF2 alpha synthesis, thereby causes bronchoconstriction. Aspirin increases leukotriene levels by increasing substrate for lipoxygenase. Okay, now see, we have this membrane phospholipids from which there will be synthesis of arachidonic acid. Arachidonic acid will be acted upon. This step will be catalyzed by the enzyme phospholipase A2 because primarily from physiology and also multiple different subjects. Arachidonic acid will be acted upon by cyclooxygenase enzymes, which in turn will be producing prostaglandins and thromboxanes. Arachidonic acid, if at all it is acted upon by lipoxygenase enzymes, then leukotrienes will be synthesized, which will bind with its receptor, thereby produces bronchoconstriction. On the other hand, these will bind with its receptor, thereby it will produce inflammation. This will be landing up in inflammation. So now what we give is we administer a drug named as aspirin. Aspirin is a cyclooxygenase inhibitor, non-competitive irreversible inhibitor. So now what happens? This arachidonic acid is getting accumulated and accumulated. More arachidonic acid, which means there will be more substrate. Arachidonic acid is the substrate available for its interaction with the lipoxygenase enzyme. So more leukotriene synthesis, more receptor stimulation, more bronchoconstriction tend to occur. That is the mechanism of how aspirin will induce bronchial asthma. So here, out of all this, let's look into the first statement. Okay. Aspirin induces lipoxygenase activity. No, it is not going to be inducing any lipoxygenase activity. Activity will remain the same, but we are just increasing the substrate concentration for lipoxygenase. We are just playing with English terminologies here. Option B, atorvastatin causes bronchoconstriction when given with aspirin at low doses. Bullshit option. Don't think about that. Option C, aspirin increases PGF2 alpha synthesis. No, aspirin will tend to block the PGF2 alpha synthesis. Aspirin increases leukotriene levels by increasing the substrate for lipoxygenase. Well, this is the most correct statement over here, and that's why that is the answer for the question. Option D is the answer for this question. Good. We'll move on, guys. We'll move to question number 19. Which of the following is there are examples of chemical antagonism? Heparin with protamine sulfate, methemoglobin or nitrite-induced methemoglobin and cyanide, sugammadex and rocuronium, bevacizumab and VEGF, vascular endothelial growth factor. See, chemical antagonism means you administer a drug and that drug is binding up with the parent molecule directly and tend to excrete it out from the body. Right? Well, that's the concept of that. Either it is going to be excreted out or it is going to be inactivating that. So here, heparin is actually an acidic molecule. Protamine sulfate is actually a basic molecule. A basic molecule will go and bind with the acid, thereby it is going to get excreted. This is an example of chemical antagonism. Methemoglobin has got high affinity, good Dr. Anuj, Saritra, Akshay, good, very much good. Nitrite-induced methemoglobin, it will bind with cyanide directly and tend to throw it out from the body. Example of chemical antagonism. Sugammadex and rocuronium. Sugammadex in turn will bind with rocuronium and tend to, not only rocuronium, also for vecuronium. It will bind with it and tend to throw it out. That's why again, one more example of chemical antagonism. Bevacizumab with vascular endothelial growth factor. Please note down that all the monoclonal antibodies are actually chemical antagonist concepts. Please note on monoclonal antibodies nothing but chemical antagonism. Not only bevacizumab, any monoclonal antibody, if it is targeting a particular molecule, that will come under chemical antagonism. That's why the answer for the question is, as most of you have guessed, 1, 2, 3, 4. All of these 4 will be the answer for the question. Good. We'll move to the last question, buddy. Which of the following conditions mannitol is not used? Again, this is a negative based question. Most of you, this is one of the easier question, buddy. Don't worry, I will help you with that. Mannitol is actually an osmotic diuretic agent. What are the uses of osmotic diuretic agents? We have a mnemonic here. OCD is the mnemonic. O stands for oliguria. In terms of decreased urine output, I can use osmotic diuretics. C stands for cerebral edema. And also for closed angle glaucoma. For 2 C's we can use. And D is for, one is dialysis disequilibrium. Dialysis disequilibrium we can use, and also for drug overdose, like your lithium overdose or salicylates, like aspirin overdose, we can use this drug. Or we can opt for barbiturate overdose or bromide overdose. In all of this drug overdose, we can use osmotic diuretics there. So here we have seen all of these options. Oliguria is there, cerebral edema is there, bromide overdose is there. But pulmonary edema due to acute renal failure is not there because it is actually a contraindication in those cases. Because in terms of acute renal failure, none of the osmotic diuretics can be given because these drugs might accumulate. It might induce development of pulmonary edema when given in patient with the renal failure. Good, guys, with this, we complete the T20 series. And if you have any doubts, any queries, please post it up in the chat box. And all the best. What else to do? All the best for the exams. And you're all, please make sure that I'm not going to be saying the same thing which all of you are already been knowing. Please have a confidence on you, right? You should have that confidence. You should have that knowledge that, okay, I have read, right? I'm eligible to do all of these things. Good. If I'm not eligible, I'm not going to be writing up the exams. You're there. You have applied for the exams. You're going to be writing up the exams. You should have the confidence there, right? Just imagine now you say okay for getting married, and you're sitting down in the marriage, no. But before tying up the thali, no, you immediately you just having a double thought. No, you shouldn't do that. If you are sitting up there, you have to do that. You are applied for the exams. You have to sit down for the exams. You should have the confidence at a high peak. And all the best. Thank you so much, Dr. Anuj. Yes, my throat was it was very much bad like 4 days before, but now I'm just recovering. Everything is good. Thank you, Saritra. All the best for all of you, and I hope we'll meet up in a good session. Like I think a rankers meet. We'll meet up soon in the rankers meet. Bye bye. Good night.
Thank you, sir.